سبيشالست لازم تحبوا البنتكام. المحاضرة التالية هي للدكتور هشام الأكحلي، أستاذ مساعد في جامعة 21 سبتمبر، استشاري قرنية تصحيح نظر مياه بيضاء، مستشفى مغربي. دكتور هشام.
رقم خمسة.
الدكتور فهد التزم بالوقت وانت التزم رجاء.
5. Glaucoma. Okay, the subject is about post-keratoplasty glaucoma. This subject aimed at highlighting the magnitude of the problem and assessment of the risk factor, also diagnosis and management. The green means go get your eyes tested for glaucoma, save your sight. Okay. As the primary goal of the corneal graft is to establish visual acuity. To establish visual acuity, you have must good visual acuity. You have clear graft and low and regular corneal stigmatism. But this threatened by glaucoma, and so you must to stop glaucoma. Okay. Glaucoma, for its complication, they defined as elevated greater than 21 within 1 month, with without visual field defect or optic disc head. Why? Because they affect the anterior and posterior segment. Anterior, they lead to loss of endothelial cells. So they are the second cause after rejection for graft failure. And the intraocular pressure is related to the duration of intraocular pressure is related to the endothelial cell loss. Also, at the same time, they affect the optic disc and they cause irreversible visual loss. So, intraocular pressure elevation lead to the endothelial cell loss and early graft rejection and over time optic nerve damage. Okay, so the importance of early detection of intraocular pressure elevation and its control, it's important for graft survival. Okay, the second topic is assessment of risk factor. There are many types of and recent surgical keratoplasty. In spite of this, glaucoma is high frequency to happen. And most commonly at false thickness keratoplasty or disc. And in general, the most common pathogenesis is synechia angle closure in this picture. You see the posterior angle closure, and the second common cause is corticosteroid-induced elevation, glaucoma. Okay, this is keratoplasty techniques. Okay, the major risk factor for both keratoplastic glaucoma can occur at any time. The incidence at early post-operative are variable according to the indication. from 9% to 31, and in the late post-operative also according to the indication, either 80% to 35, and can classified pre-operative, intraoperative, and post-operative. Okay, this is the more high risk for post-keratoplastic glaucoma. The most common is pre-existing glaucoma, and the second is aphakic and pseudophakic bullous keratopathy. Also, perforated corneal ulcer is related to the past or posterior angle synechia. Regraft is related to the thickness of peripheral cornea is more than the central. Also, combined penetrative keratoplasty and cataract extraction is a high risk. Here also herpes simplex keratitis is very high risk, while keratoconus or corneal stromal and endothelial dystrophy is low risk for development post-keratoplastic glaucoma. Wait. Okay, intraoperative risk factor, the most common is viscoelastic material. So you have clean it before close the eye. Tight and superficial suture with long bites is very important, lead to the post-keratoplastic glaucoma because they change the contour of the contour of the angle. Also, larger travel size, more than 8, and increased peripheral corneal thickness, and donor smaller than host. These all lead to the glaucoma, post-keratoplasty. Causes of early post-operative, the most common, we said viscoelastic. Also, papillary block glaucoma is very common with DASIC and air bubble, because air bubble cause the papillary block glaucoma. The post-late posterior post-operative period is very common with steroid-induced glaucoma. And in Yemeni patients, because there is no, in the rural area, ophthalmologist, and the long distance to arrive to the doctor, sometimes this happens due to steroid-induced glaucoma. Okay. The challenge about post-keratoplastic glaucoma is about the diagnosis and the management. How? Okay. Following penetrating keratoplasty, surface irregularity and scarring and increased corneal thickness, these prevent precise intraocular pressure measurement. So there is some techniques that don't depend on the thickness, like mere electronic augmentation tonometry and the pneumatic augmentation tonometry, tonoben. This can elevation of intraocular pressure. If the corneal surface graft is smooth with intact epithelium and regular Myers, you can use Goldman. The assessment of optic nerve and visual field either before or post keratoplasty is very difficult because we have hazy media and perioperative, and we have high corneal stigmatism, and sometimes there is corneal edema in the first week, so very difficult to assessment of the optic disc or visual field. Management. Glaucoma management also remains challenges for treating ophthalmologists. They are either medical or surgical, but also medical can be benefit, but some patients have to go to the surgical intervention, including filtrating surgery with mitomycin or the glaucoma drainage device. And there is controversial. What is the success rate? This is depend on the survival of corneal graft. And with duration after 1 year and 1 year, the survival is less. So the prevention frequency of follow-up visit in routine cases, you have to see the clearacy and intraocular pressure. Also the steroid using, you have to tapering the steroid during the first 3 months, or then you have used mild steroid with tapering. Okay, summary, early diagnosis is mandatory for optimal grafts and optic nerve head function. Glaucoma, common complication, cord transplantation, and degree aggressive is offered to indicate